Hi, I am Dr. Lourens Coetzee, a refractive surgeon at Sandton Eye Clinic.
And I'm Dr. Yolandie. I am a general practitioner and I love medical education. And today we're making a little video about cataract surgery and what to expect and what options there are. So Dr. Coetzee is helping us today with that. So did you know that worldwide about 26 million cataract surgeries are performed every year? So that's quite a lot. And because of that, this is a very reliable and effective procedure because it's done so often. So it's a quick 15 to 30-minute procedure and it actually changes your vision very quickly. So some patients have been wearing glasses all their lives and they don't mind to continue wearing spectacles. But cataract surgery is also a unique opportunity to get the options to be less dependent on spectacles.
So, it is like an ideal opportunity to actually address refractive errors, or that is the refractive or your reading of your glasses. So, because we actually choose the type of lens and the strength of the lens that we're going to replace your cataractous lens with, and we're going to talk a little bit about why do cataracts develop and what is a cataract and how it's like specifically addressed. But just talking about lenses and the fact that you can enhance your vision with this procedure, not only addressing the cataract per se, but also giving you better vision than what you had while like when wearing spectacles.
So let's start off by just doing the basics. So what is a cataract?
So within your eye, there's a lens. And there's actually multiple lenses within the eye, and we've actually talked previously about the cornea and diseases of the cornea, specifically keratoconus. But that is the most outer lens, and then inside the eye, there's a small structure. It is called the lens, and the function of this specific structure is to actually focus the image sharply on your retina, whether it's an object in the distance or an object nearby, close nearby. And as you age, this lens becomes dysfunctional. So a nice term that we use these days is called dysfunctional lens syndrome. And dysfunctional lens syndrome is starts off in your 40s, and that's where the long arm syndrome actually starts. And the long arm syndrome, that's where you start to need reading glasses. That is followed by by the next stage where you'll have a little bit of yellowing of the lens, you start losing contrast, a bit of difficulty driving at night. And stage 3 is where you actually develop a cataract. So, and that's where there's an opacity forming within this lens. So this lens opacify, and no matter whether you wear glasses or contact lenses, the image will not be clear because the rays entering the eye is actually blocked by by this by this cataract. So a cataract is not something growing over the eye or like a growth over the eye that most people think it is. It is inside the eye, the lens becoming cloudy. And if you leave it in advanced stages that we rarely see these days, you can actually see a white pearl in the eye. So that's actually what a cataract is. If you leave it, that white pearl that all people might have. Guys, why do we develop cataract? So by far the most common cause of cataracts is aging. So we call it an age-related cataract, and that the average age for that development is usually in your 60s. So there's other reasons, and that's where we see cataracts at an earlier stage, for instance, diabetes or any type of metabolic disease. Also trauma or infection in the eye, and then in some cases, children are born with cataracts, and we call that a congenital cataract. And that's a whole topic on its own. So here we're only going to discuss the age-related cataracts or cataracts that develop due to age. from sun damage normally, and just normal, like normal aging. So timing for surgery. When do we decide to do cataract surgery? So a term that I don't like to use the term cataract surgery. A better term to use, or that we use these days, is called custom lens replacement, because you are actually replacing the lens, and you can actually decide what type of lens you want to use depending on the patient's lifestyle and needs, as well as the eye itself. So timing of cataract surgery, I divide it in two groups. Okay, the most common group is patients that find that their vision is affected with their glasses. So they were wearing glasses, and they were happy with their glasses, and they went to the optometrist, and the optometrist, like, because they can't see that so well, and when the optometrist tests, they find that they just can't get a clear image. And so the optometrists know that when they're going to prescribe glasses for this patient, he will still not be happy because there's an opacity within the eye. So that's the correct timing, like for surgery. When the patient feels that their daily activities is affected, and they can't get clear vision with their glasses. So if we see, for instance, a patient, and often like an ophthalmologist or an optometrist will say, I can see there's a cataract, but the patient is happy with their vision. They feel that they're functional, then we're not going to operate for that specific reason. And we will wait, and the surgery is actually determined by the patient in most instances. Then the other reason for doing cataract surgery or custom lens replacement is when a patient comes and see us in the practice, and they say, I don't want to wear glasses. Often these patients will come for laser vision correction, and when we examine this patient, we find actually that there is a cataract, and that if we're going to do laser vision correction within a year or two, that cataract might be so significant that we have to do a lens replacement. So makes much more sense addressing the refractive error or the spectacle error with custom lens replacement, and using a lens for this patient, so that, or this procedure, to give the patient spectacle independence. It is important to note, though, that this is an refractive procedure or a lifestyle procedure, and that this is not covered by medical aid, because we're not addressing a physical disease in the eye like a cataract. The cataract is not so significant that it is actually causing functional vision loss. Whereas if the cataract is significant enough to cause functional vision loss, it is affecting the patient's daily activities, even if they wear glasses, that is normally covered by a medical aid.
So you previously talked about diabetes as well, and it's important for patients to just realize that cataract surgery will not cure you from other eye diseases. Like 35% of diabetics over the age of 40 have diabetic retinopathy, which is a disease of the back nerve part of the eye, which cannot be fixed by cataract surgery. And then also, as patients age, about 25% of patients over the age of 60 have AMD, which is also a disease at the back of the eye, which cannot be fixed by cataract surgery. Glaucoma is also another disease that affects the back of the eye, that cannot be fixed with cataract surgery. And it is important to realize that your cataract surgery may fix the cataract problem, but that will not fix any other eye diseases. So that you don't, so you must know what to expect, and that's why you need proper examination by your surgeon, so that they can tell you if you have any other problems that might affect the outcome of the surgery.
So this is actually quite important, because often we sit with this clinical dilemma as surgeons or ophthalmic surgeons, is whether is cataract surgery going to benefit this patient if there's another disease contributing to the vision loss. We might often decide to delay cataract surgery if we feel that doing the procedure is not going to benefit the patient that much. Or what we also sometimes find that we we have we think that it will benefit the patient and we proceed with the surgery, and then we actually fail to meet the expectations of the patient because the result is marginal or the improvement is marginal. It also needs to be noted that if um, sometimes we need to perform the cataract procedure to address the other pathologies, like we just to get a clearer view of the back or the posterior or the back part of the eye. For instance, if there's diabetic retinopathy or bleeding from the retina due to diabetes, and to address that. It's what I also need to just mention is that if you've got concomitant disease or if there's another ocular disease that affects vision, you will unfortunately not be able to get or we will not be able to implant a lens that's going to give you spectacle independence, because often these lenses actually will work, will have the opposite effect. You'll actually see worse with these lenses than just with a normal, straightforward standard monocular or a monofocal lens.
Okay, so it sounds quite complicated. When a patient comes to you for cataract surgery, which tests will be done? What can they expect, and what will you see from that to determine what procedure will work best for them?
Okay. Yeah, so when so because we want to identify other diseases and we want a perfectly normal, healthy eye, apart from the cataract, when we want to perform what we call a custom lens replacement with these multifocal or extended focus lenses, that's going to give a degree of spectral independence. We need to make sure that we look at all the various structures. And when I see my patients and we go through all the tests, I normally start either from the back or the front. So if we start from the back, we, for instance, do an OCT scan of the nerve. So an OCT scan is where we use light, like a CT scan, where a CT scan uses X-ray waves and MRI uses sonar or radio waves. OCT uses light, and we go and we look at all the various structures at the back of the eye. And we look at the nerve, we see whether there's any signs of glaucoma. We look at the macula, which is like the CCD or the film of the eye, and we see whether there's signs of macular degeneration or whether there's a little scar tissue growing, we call it an epiretinal membrane. And we move a little bit into the front, we look at the lens, we try and quantify the opacity. There's various instruments like the eye trace or the HD analyzer, we call it. This is just fancy words, but we look at what we try and quantify the degree of the opacity. And then we move to the front and we now specifically look at the cornea, and we want to see whether there's astigmatism. So astigmatism is where the cornea, the front window of the eye is shaped like a rugby ball, because that can also be addressed at the time of cataract surgery. We also want to see is there enough cells that's going to keep the cornea clear. Because when we perform cataract surgery, we actually reduce some of these cells that's responsible for keeping the cornea clear. And we just want to make sure, is the cells healthy? Are there enough cells? And then, of course, we end up with a general test where we look at vision, we look at pressure, and we also look at your tear film, which is very important because tear film is temporarily affected with any type of surgery, eye surgery, whether it's cataract surgery, laser surgery, glaucoma surgery. It does affect the tear film temporarily, and the patient can struggle with a bit of dry eyes for up to 3 months after the procedure.
Okay, so when a patient goes for cataract surgery, it's quite precise and complicated, and it's done under a microscope. But can you maybe just explain to patients that when they go for cataract surgery, what exactly is done, what will happen to their eye?
No. So I think the first thing that we need to tell our patients that it's not painful, and often we use just sedation. We don't, we're not going to give you general anesthetic. And when you have sedation, you fall in a light sleep, but we can wake you. So often patients don't even remember that they've gone through the procedure. In our practice specifically, we use topical drops to anesthetize, and you'll probably be already used to it because we use the same drops in the consulting rooms when we want to measure pressure, for instance, or we use a specific dye to look at your tear film. So there's also centers where they use a block, we call it, where they use local anesthetic externally via an injection, which is also not painful. Just have to mention that is not painful, just to keep the eye nice and still. Then we perform the procedure. When we perform the procedure, we sometimes add, we usually add some local anesthetic after we've made the wounds inside the eye, just to make sure that the patient doesn't feel anything. So this is definitely not painful. How we address the surgery, or how do we go about it? There's normally 2 to 3 wounds made. The largest wound is not more than 2.4 millimeters, so it's very, very small. And after we've made these wounds, we open the little capsule or the bag where the cataract or the cataract's lens is in, or the bag containing the lens. We call that a CCC, or a circular capsulorhexis. Then we use sonar to emulsify the eye, or not emulsify the eye, emulsify the lens, and we just like suck it out. And then when all the cataracts material is removed, we then implant the lens in that same little capsule bag that contains the lens. And then usually when we finish off, no need for sutures, or there's no need for sutures. It's self-sealing wounds, and it takes about 20 minutes per eye. And recovery is all, like it's usually within 2 to 5 days, depending on how severe the cataract was. If you've got a very dense cataract, you can expect some blurry vision the following day, because we have to use a lot of energy to actually break or emulsify that cataract.
So maybe you can tell us a bit more about the options of multiple of lenses when you have cataract surgery, and the possibility of seeing without glasses afterwards.
So I think the first thing that we need to mention again here is that if a patient wore glasses before the cataract procedure and they're happy with their glasses, then we tend to use a monofocal lens. A monofocal lens means it's got a single focal point. We might address astigmatism at the same time with a monofocal toric lens, and the whole aim is to give that specific patient the best possible vision at one single point. And these lenses are excellent for patients that as I said, are happy to wear glasses, and they just want to have the most perfect vision, and they don't mind wearing glasses for reading, for instance, or don't mind wearing glasses for distance. And also there are patients that we can only use these monofocal lenses because of other pathology. If a patient, however, feel that they don't want to wear glasses or contact lenses, and they do have cataracts, then we can opt for a multifocal or an extended focus lens. And I will allude to, or I will elaborate a little bit more later. But it is important that with all of these premium lenses, we call it, there will be some sort of compromise, and we can't, the lens that we're going to use, no matter whether it's a monofocal or a multifocal, it is not the same lens. We can't give you the same quality lens that God created for us, a God-given lens. So there will always be some compromise, even with the premium lenses. So with the various types of premium lenses, there's various types of compromises, but also various types of advantages. And it's the refractive surgeon's job, together with the patient, to choose the best lens that's going to suit their lifestyle, and then also the overall health of the eye. So when we look at the types of lenses, we do have, like we get the trifocal lenses or diffractive trifocal lenses, and these lenses divide light in three focal points. So you'll have a very good vision at distance, and very good vision at near, and relatively good vision at intermediate, which is around about 70 centimeters. So there we aim to give the patient spectral independence, let's say 95 to 99% of the time. And sometimes they might require glasses for the intermediate part, the 70 centimeters part, but the vast majority are spectral independent. The compromises of this specific lens, there's usually three that I discuss with my patients. The first one is halos at night, and the halos at night will get better as time goes on, but it never goes away completely. And the reason for that is because of the concentric rings that divides the light in three focal points. The other compromise that you will be able to read very, very clearly at 40 centimeters, but you need good light. And a practical implication here is that if you're in a restaurant, you want to read the menu, you'll be able to read the dishes and comfortably, but when you want to read the ingredients, you'll probably need to tilt the menu towards the light, or take a little cell phone out just to read a very small fine detail. And then the third compromise, as I've said, especially for our accountants that use a lot of Excel spreadsheets on desktop computers, they might, especially if they have to use, they have to work extended hours, they might need to use computer glasses. Um, but overall, a very high satisfaction rate. If we look at how satisfied patients are, 90% of our patients are super happy. 9% will say it's okay, but the compromises do bother me. And there is 1% of patients that just don't adapt with these lenses. So of course we try and identify these patients beforehand, and we look for all possible causes why a patient is not happy with a trifocal or diffractive trifocal lens. But if we see that the patient just don't cope, and we've given sufficient time for this patient to adapt, then one can exchange this lens for a monofocal or an extended focus lens, just so that they don't sit with or have different type of compromise. Then looking at the extended focus lens, this is a type of lens that will give you a less range, but a less but continuous range, a range of vision. So these patients or these lenses will give you less spectral independence, but give you a wider range of continuous vision. And we will often use what we call a mixed match or blended vision, where we either use two different type of extended focus lenses just to widen this range of vision without glasses, or we can use the same type of extended focus lens but different refractive targets. Basically make the one lens for distance and the other lens more for computer work and reading. And there's also an adjustment there, um, but less so with the trifocal lenses. For instance, you have less dysphotopsia, so less night halos and night vision symptoms, and probably a little bit clearer vision in dim light, but you won't be as spectral independent as with the trifocal lenses. So what I normally tell these patients, if you want to quickly look at your cell phone, you'll be fine. If you want to quickly read an email, you should be fine. But if you're going to spend 3 hours reading a book or 3 hours behind the computer, you will need a pair of reading glasses. So all of these lenses are excellent lenses. One should never think that a monofocal lens is inferior to a trifocal lens, for instance. They've got their strengths and weaknesses, and it's important to choose the lens that fits the patient's lifestyle, but also the patient's eyes and the patient's expectations.
Okay, thank you very much for the nice explanation. So lastly, patients like to plan their life. What should a patient expect when they have cataract surgery? When can they fly? When can they swim? When can they go on holiday?
Okay, yes, so as I've said, the cataract procedure is a day procedure, so you can normally go in the morning, go out the midday or the afternoon, and in most cases you will go out with a clear shield. Sometimes there's a little sponge that they also give you. The following morning your vision will in most cases be relatively clear. Remember, there are in certain cases where the cataract was very hard and the cornea takes a while to clear up. So if you have blurry vision the following day, don't stress. Okay, sometimes people do have blurry vision, it will clear up eventually. So then if you, let's say you had a like normal density or relatively normal density cataract and it was an uneventful procedure, then your vision will be around about 80-90% the following day. You are going to have a shield that you're going to wear at night when you want to sleep, and so you don't wipe your eyes. Normally we say that after about 72 hours patients can take a shower and wash their hair, but you just never press on the eye. Remember, the wounds are not, there's no suture in the wounds, and if there's going to be pressure from the outside, you can open those wounds. If it was an uneventful procedure, normally you can fly within a week. You can also return back to work within 2 to 3 days. Exercise, normally I would say like after 2 weeks you can have like mild exercise, start walking around the block for instance, and after 4 weeks you can continue with your normal exercise routine. No swimming for 4 weeks, and that is important. And usual drops, of course, 4 times a day, so you just need to, in your scheduling and your work routine, or how you plan your 4 weeks of the procedure, just make sufficient time to put in your drops. And yeah, it's actually a relatively quick and unremarkable recovery.